ठीक है, alternate. One vote only, that's for alternate. So ठीक है, unanimous. Let's see. So taste of both the things. Amit will alternate then, right?
Alternate, okay,
Yeah.
fine. So, good afternoon, everyone. So we are obstructing your way from your lunch. So hopefully you are not sleepy. Dr. Sushmita talked about like what pediatric ophthalmology is all about. So you have to be very passionate about this branch because the entire lifespan of the child is in front of them. We usually consider refractive error as a very trivial problem, but mind you, this is the most important entity that we should be knowing. And I can bet that most of the general ophthalmologists, or for that matter, any specialty ophthalmologists, this is the topic that disturbs them a lot. A lot of them, they are not clear when to prescribe, how much to prescribe, and what is the impact of this in terms of the amblyopia management, overall development of the child, and what we are looking at. So, when we are discussing about refractive error prescription in children, the clinicians, they need to know what is the need for the child. So we are looking at the embryogenic potential, we are looking at the development of the child, we are looking at the orthoptic evaluation of the child, we are looking at all the parameters, and accordingly we decide what is the developmental delay, whether the child has nystagmus. So all the things, they come into play, and then only we arrive at a decision that this is what we need to prescribe. So there can be no single parameter that you look at, and it is not only the cycloplegic refraction we are looking at the entire gamut of thing. I usually tell my fellows that evaluation in pediatric ophthalmology starts the moment the patient is entering into your clinic. You examine the patient when the child is entering, the kind of head posture the child has, the kind of gait the child has, the mannerisms the child has. So we are looking at the visual behavior of the child. So all these things, they come into play to decide what exactly to be prescribed. And then we have some common beliefs of the parents, the grandparents, the society. The child is too young to wear glasses, the child is not going to wear glasses. It would be difficult for the child to keep the glasses on. Wearing glasses will increase or decrease the power, and we don't need to check the glasses. You reduce using the glasses power, tends to decrease the power, and it does not increase in future. So we have to emphasize this at every visit, that they need a regular prescription, regular checkup, because children can have a progression of their myopia, there can be regression of hyperopia, and there are a lot of other things that we need to keep on looking at. The prevalence of refractive error, if we do a eye screening camp in a school, is close to 10%. So that is the amount of load of children that we come across with refractive errors, and it is increasing by the day, and the amount of myopia is increasing very, very significantly, and we are expecting a pandemic of sorts of myopia in times to come. So we'll have roughly 50% of children by the year 2050 with myopia. The younger the child is born, children are born hyperopic. So as the eyeball grows, so there is an active and a passive hemetropization process which goes on, and that tends to decrease the power of hyperopia in times to come, and a lot of these children, they become emetropic, and a progression of that leads them into myopia. Younger the children, more the chances of an unstable state of refraction. The lens keeps on becoming, it is thick to begin with, it tends to thin out. So there are a lot of changes which are happening. Anterior segment, it keeps on changing. So we have to rely on objective refraction more rather than subjective refraction for these children. So we are relying more on cycloplegic refraction, our skill, rather than the child's response. The child is not going to give you a response that I am seeing better with this or this, especially a child below 3 years of age. And whatever the prescription you are giving, it is going to have an impact on the overall development of the child. If we are prescribing a good refraction to a child who has a developmental delay, their developmental milestones, they keep on picking. So we need to understand this, and we should be emphasizing this to the parents as well. Older the parents, older the child, more likely the child is going to be myopic. Subjective refraction would be much more important in these children, because child is going to respond to whatever you are asking them. A non-strabismic binocular visual disorders, NSBVD what we call, would be more important for you to emphasize what exactly you will require. So I'll just show one slide and we'll just keep on dwelling on that only. So these are probably you must have seen this tabular form in a lot of presentations, or you must have gone through AO guidelines, or you must have gone through a lot of prescription guidelines for children. So these are the joint guidelines which have been prescribed by American Academy of Ophthalmology, American Academy of Pediatric Ophthalmology and Strabismus. So if you basically look at this, for guidelines regarding myopia, what are the requirements of a child, say an infant? How do we derive this? 5 minus 4. So there should be some logic behind this. Why we are not prescribing anything more than minus 4, minus 5? Anyone? Anyone has some logic why we are not prescribing this? We see a lot of children. Anyone? What is the working distance of a child? So
The focal length of the glass.
So
versus-
what the child actually requires is the child has to look at faces of the parents or anybody who's around. So that is the working distance of a child. So that is close to 20 to 33 centimeters. So that is the range the child needs to have a clear vision of. So anything beyond this is not what the child wants to see or would require to see. So up till that diopters, minus 4 diopters, we can safely ignore for that age group. Similarly, if we come across a child in the age group of 2 to 3 years, what is the visual requirement? The child would be going to a kindergarten. And their mode of education is mainly verbal. So they're looking at their copies. So for that child, the working distance is going to be 33 centimeters. So for 33 centimeters, if you inverse this, 1 of focal length, 3 diopters. So up till 3 diopters, in a child less than 3 years, you can safely ignore. So beyond that, it becomes more and more pertinent to prescribe that. So that is the logic behind why we are prescribing this and we are not prescribing that. Commonly, when I ask my fellows, they don't have a logic. So everything in pediatric ophthalmology per se, everything has a logic. If you are looking at something and you are not able to answer that, you are in a fool's paradise. That is precisely my answer. That you have to have an answer for everything. A child is not looking at this, you need to have an answer why the child is not looking at this thing. So if you are able to answer yourself, so we are answering ourselves, because the child is not giving you any answer, so it is like a veterinary practice. Like you see your pets, the pets are not going to respond, children are like that. So you have to have everything in your clinical examination and derive what exactly we are dealing with. Similarly for hyperopia, plus 5, we don't prescribe. So there's a caveat to it. What exactly we are looking at? Anything else that we need to pay attention to? Anyone? So orthoptic evaluation is very important. So you have to look at the child has an esophoria or esotropia. If the child has an esotropia or esophoria, you have to give the full prescription. And what do I mean by a full prescription? What is a full prescription here? Anyone? So we don't have to deduct for the cycloplegic agent also. There we don't deduct for the cycloplegic agent also, and there's commonly a debate which cycloplegic agent to use. So commonly worldwide, the pediatric ophthalmologists have a general consensus that cyclopentolate followed by tropicamide followed by cyclopentolate. This is the new norm that we have set in, and this is since the last 10-15 years. So CTC is what we call them. So first installation of cyclopentolate followed by tropicamide installation after 5 minutes, and another 5 minutes installation of cyclopentolate, and then you do the refraction after 30 minutes of the installation of the second installation of the cyclopentolate. So if you have a child who has an esophoria or esotropia, you will give the full cycloplegic refraction. For a child under 1 year of age, if the refraction is plus 5, plus 6, you can safely ignore, because we expect this child to have an emetropization process, and this child won't require any prescription. Beyond this, if there is a hyperopia which is there, I am talking about the dry refraction. So if there is a refraction beyond this, say a child comes to you with plus 8, so I'll give a 50% prescription, because this child is not likely to have an emetropization, and this kind of refractive error is going to be amblyogenic for the child. So we want to prevent the onset of amblyopia in the first setting. So I'll prescribe something like +4. So our logic has to be there, what exactly we are looking at, and there are certain conditions where we are not very sure regarding the refraction. So there my follow-up duration would be lesser. So I'll tell the parents that this is what I'm getting, and I want the child to come back to me after a month. I want to repeat the refraction, and accordingly I might prescribe it. 1 to 2 year old child, again up till 5 diopters, we can safely ignore, because this much the child is able to accommodate also. And if there is a esotropia or esotropia is there, definitely we'll be giving a full prescription. When the child comes to around 2 to 3 years of age, up till 2.5, 3 diopters of hypermetropia, you can safely ignore. Reason being, the child has a very strong accommodative mechanism, even if the child is not having any esotropia. If the esotropia is again the prescription guidelines, full cycloplegic refraction. So hyperopia with esotropia, where it is mentioned. So what essentially is infantile esotropia? Anyone? It is mentioned in Kansky also. Everything is mentioned in Kansky. That is probably the book you must be reading, I guess. So infantile esotropia we classify as a child having an onset of esotropia in the first 6 months of age. Usually the amount of esotropia will be more than 40 diopters, and the amount of hyperopic correction, cycloplegic correction, would be less than 2.5 diopters. So essentially these would be the patients who would be non-accommodative ones. So that's why this is mentioned that this much amount of hyperopia with esotropia we need not correct. But there are patients where 1.5 diopters of hypermetropia also has an accommodative esotropia. So we have to look at every parameter, and accordingly we decide what exactly we need to prescribe. I would say 80 to 90% of us have some amount of astigmatism. 0.5 diopters I also have. I have not been prescribed in my glasses because I'm not comfortable wearing that. If the amount of astigmatism is up to 2.5 to 3 diopters, mind you, it is with the rule or against the rule. Up till 1 year of age, we can safely ignore. How do you define with the rule or against the rule? Anybody? So we take it 15 degrees on either side. So 15 to 165, 75 to 105. So this we call as with the rule and against the rule. Anything lying between this is oblique astigmatism. So with the rule, against the rule, astigmatism up to 2.5, 3 diopters, we can safely ignore, because this is not going to be amblyogenic for the child. If the moment it crosses beyond this, 50% again I'll prescribe, even in an infant. If it is an oblique astigmatism, I'll definitely prescribe, because oblique astigmatism is much more amblyogenic compared to with the rule or against the rule astigmatism. As the child keeps on increasing in age, our prescription threshold keeps on decreasing. So if I come across a child in the age group of 3 years, I'll prescribe a 1.5 diopters of with the rule or against the rule astigmatism also, because this is going to impede the overall development of the child, the visual development of the child. Then what kind of anisometropia is most likely to be amblyogenic? What kind of anisometropia? That you come across in your OPDs also. You must be seeing it on a daily basis. So anisohyperopia is the most common form of refractive error which leads to amblyopia, for a simple reason: the child is not able to accommodate. So there we need to prescribe that, and child is not able to clear that kind of anisohyperopia. So we need to prescribe that as early as possible. So anything more than 1.5 diopters of anisometropia is more likely to be amblyogenic compared to anisomyopia. Up till 2.5, 3 diopters also can be accepted by the child with no development of amblyopia. Astigmatism 1.5 diopters. Beyond that, if you have an astigmatism, that is also amblyogenic. Beyond that, we also look at the child has any nystagmus, any developmental delay. So all these things, they come into play when we are deciding what kind of refractive prescription the child has to give. The example that I can give you is, if you see a child with Down syndrome, these children, they usually have an accommodative lag. They are not able to accommodate for the targets they are seeing. So once we do a dynamic retinoscopy for them, a lot of them, they would require a hyperopic prescription. And moment you prescribe their hyperopic prescription, you'll see a smile on the child's face. That would be mainly because the child is seeing the faces for the first time clearly. So that we need to understand what is the need of the child. Similarly, this is the case with a lot of children with cerebral visual impairment. A lot of them, they have an accommodative lag, and we need to prescribe them this 1.5 diopters of hyperopia also, even if these children are in the range of 1 to 2 years of age. So their requirement is entirely different. Another factor that is important for us to know is the refraction of the parents, or if the parents also had a history of accommodative esotropia to begin with. So this would be another indication where I would err on prescribing rather than non-prescribing, because a lot of them, they would develop amblyopia later on, which we could have avoided if we would have intervened earlier. So we always say that prescription of glasses in children is a combination of science and art. Science is, we need to know the cycloplegic refraction. We need to know the age normative database for that particular age group, what the child would require at that age. Is it embryogenic for the child? How likely this is going to be metropized in future? And art is, we need to know our cycloplegic refraction. We need to be skilled at retinoscopy, which is very, very important. Assess the visual behavior of the child. How is the child moving? Any particular mannerisms the child has? Any particular gait? All these things, they give a clue regarding what kind of vision the child can have. Assess the visual demands for that particular age, like I mentioned earlier also, and assess other comorbidities and family history, like we discussed. Thank you.
Thanks, Amit. It was a wonderful talk and a very meaningful talk. I think it was very important that how to prescribe glasses has shown a wonderful chart and very well discussed. I think by the time I settle on my, I'll do it in your laptop only. So you can have a couple of questions. One question from my side, Amit. Like you said, you can avoid a particular amount of hyperopia prescribing in a child. That was probably you meant by binocular hyperopia.
Yes.
If the child has uniocular hyperopia, kindly tell the audience, then you have to prescribe.
That I discussed regarding NSO hyperopia. So NSO hyperopia, the guidelines are different. If it is isometropic, there is the guidelines are different. So hyperopes, there are two kinds of children. One would be the ones who would try to fix for something. Those are the ones who develop accommodative esotropia, compared to the ones which are cool dudes. They won't like to fix anything. They'll develop isometropic amblyopia. So this is how we essentially divide these high hyperopes to be. One would develop accommodative esotropia, one would have this isometropic amblyopia with say +6 refraction both eyes. They'll be somewhere around 624 with the prescription. So these are essentially the two categories that we come across.
Okay, good afternoon again. And I really thank Dr. Suresh, who's so passionate about teaching the postgraduates, and also to the present students who have been, I guess some of you would have missed your lunch for this, but I guess we'll make it worth that you get some knowledge about these things. After learning so many things about the pediatric ophthalmology and the evaluation, I will discuss about the evaluation and management of ptosis, which is again a very common condition. By ptosis, we know that it is drooping of an upper eyelid. It could be either one or both the eyelids. Could be either congenital or acquired. These are the important things which you should always know. This is one slide you should remember, because these are the parameters which you need to measure, and these all would nearly complete your TOSIS evaluation. So we'll take up each and everything one by one. I would prefer playing a video for the evaluation, because that will be covering most of the things. This video was made by my colleague Roshmi Gupta in LV Prasad Institute. इसी में से हो जाएगी या अलग से करूं? So this video shows you how to measure and what all measurements are there. अलग से कर लेते हैं इसमें, इसको मिनिमाइज करके ना. कहाँ पर है? सपोर्ट नहीं कर रहा क्या वर्जन? Which mode do you use for video playing? ऐड किया हुआ है बट प्ले नहीं कर रहा, इवन सेपरेटली भी प्ले नहीं कर रहा. डैट मोड में है मेरे, उसमें तो प्ले कर रहा था. ओपन विद करो, ओपन विद करो.
नहीं क्या? मैंने कोई यूज़ नहीं किया. ये कुछ और तो नहीं है?
नहीं. As the video is not playing, otherwise it would have been a wonderful thing. I have not made complete slides for that, because it was a wonderful video. So what I will do is, I'll also discuss on the basis of the slides which we have. Okay, vertical fissure height. So vertical fissure height, we all know it is the measurement between the lower lid margin to the upper lid margin. So you have to see the patient's measurement in the primary gaze. That is very important. The patient has to be fixating in the primary gaze, and you measure preferably with a transparent ruler or a opaque ruler on a centimeter scale. Margin reflex distance is the distance between the reflex when you shine a light in the primary gaze of the child, the reflex which is seen in the pupil, that from that reflex to the upper lid margin. So that's margin reflex distance. This is again very, very important, especially because if the patient is having strabismus, the reflex would be deviated, it won't be there in the center. So you would also know that the patient is having squint along with, and you have to fixate the child and then again do the margin reflex distance. It has to be determined individually, right eye and the left eye. Then there is a margin crease distance. That is the distance between the margin, that's upper lid margin, and the crease of the upper lid. Sometimes you do not have a crease, or you have a multiple crease, or you have a faint crease. Then you mention in your documentation either an absent crease or a faint crease, or you have multiple creases. The most prominent crease is then mentioned. Margin crease distance is important because that determines the site where you give an incision. So this margin crease distance is seen when you ask the patient to look in a down gaze. It cannot be done in a primary gaze because there will be a hood of the upper lid which is covering the margin, the crease. LPS section is the most important part because this will determine what type of surgery you are going to plan and how much of the resection, recession, or whatever you need to do. LPS section is seen because there is an overaction of the eyebrows in cases of ptosis eyes. So what you do is you have to hold the eyebrow, you have to put pressure of the eyebrow, ask the patient to look in the extreme down gaze, place your scale in front of the patient, and then you ask the patient in the same position to look in the up gaze, the extreme up gaze. So the excursion of the upper lid from the down gaze to the up gaze, that is the LPS section. If the LPS section is very poor, which is about less than or equal to 3 millimeters or max 4 millimeters, that is poor LPS section. 4 to 6 millimeters excursion is fair LPS section, and 6 plus is fair to good. A very good LPS section is beyond 10 millimeters or so. So in poor LPS section, you plan to do surgeries which are either resection, high on resections, or sling surgeries. Where you have a good LPS section, there you can go with an LPS plications or resections. I'll show that next slide how to determine the surgery. Sorry. The Bell's phenomena, again, you all know it's very important. You ask the child to close the lid or to go in a sleep mode, and you just try to lift the upper lid and see what direction is the globe in. It's called the Bell's. The globe should move in out and up direction. There could be an inverse bell or a reverse bell when the eye moves in and up direction or in the opposite direction. That is downside. Lag of thalamus is very important. Again, you ask the child to close the lids slightly, not very firmly, and you see whether there is a lag of thalamus. You measure it because you have to document it. It's a pre-operative lag of thalamus, and mostly in cases of ptosis surgery, the lag of thalamus, there is chances that it will increase. Marcus gun phenomena, again, we all know that's a jaw winking phenomena. You ask the patient to move the jaws from side to side or open the mouth. Along with that, you can sometimes see that there is a lift of the eyelid. So that's called jaw winking phenomena. That's positive. If there is a positive jaw winking phenomena, then you measure how much is the excursion of the jaw wink. When the child moves the jaw, how much is the lid moving from lower lid to the upper lid? That's the excursion, that's the extent of Marcus gun phenomena. Vertical tarsal height is also important in case you are planning an tarsomolarectomy type of surgeries or fasanella type of surgeries, in which you evert the lid and you measure the vertical tarsal height. So how much is the height? Generally it's 8 to 10 millimeters in the vertical tarsal. So these all are important. That completes most of the ptosis workup. There are so many more things like Schirmer test, the neurotrophy thing, the corneal positions, the inferior scleral show, but these are the most important things. I wish the video would have played because that was a wonderful video covering everything, and you could have seen it in a diagrammatic and animation form. These are the various surgeries which we plan to proceed for the ptosis. One is the molarectomy, which is the common one, in which we have a mild ptosis, but we have a very good LPS. So this I have tried to go in mild to severe form and a very good to poor LPS section. So this is sequenced in that form. So molarectomy for very good LPS section and a very mild, less than 2 millimeters of ptosis. Next is Fasanella servette procedure. Again, good to very good LPS section in a mild ptosis. Again, 2 millimeters. LPS plication in a good LPS section or even moderate LPS section. So now we are coming down the LPS section, but increasing the severity, and mild to moderate ptosis. Then LPS resection is for moderate LPS section with moderate to severe ptosis. But if there is a severe ptosis, then you can plan Whitnell sling, which is again tackling the LPS, and or tarsofrontal sling. Could be done with two methods, facial etta sling and silicone rod sling. I may not go into very much detail because you are a student, so I think you should know the basics rather than going into surgical steps. You're not going to perform it in the examinations. This is what is called the surgical rod sling now, because nowadays it is the preferred mode. Facial etta sling is not performed so well. Of course, it has its own limitations. It's a silicone rod which is of 40 centimeter in diameter, 0.8 millimeters. It is switched over the stainless steel needles. So this comes along with these needles, and you have to go through the passage or forming a pentagon from the lid towards the lid margin. Post-operative care, we all know systemic antibiotics and anti-inflammatory antibiotic ointment and sutures. Lubricant drops are very important. Not only drops, but or ointment is to be given, and the patient has to be told that these have not to be missed. Frost suture can be placed in case you are doing a lot of resections, and especially in sling surgeries. Frost suture is a suture. Can anyone tell me what's the frost suture? You don't have ptosis surgeries being done in your centers? Yeah, tell me. So from the lower lid, you put a suture and you target and keep it on the forehead. So it's to enable the lower lid and to close the lid and to reduce the lag of thalamus, because in the initial few days, the child or the patient would have painful upper lid. He or she may not close the lids properly. And so that would cause exposure keratopathy. To avoid those in the initial few days, You put a frost suture that can be removed depending upon the leg of thalamus in about 4 to 6, 7 days. Forehead sutures can be removed after 7, 10 days in cases of sling, because we have only the forehead suture in case of sling. Otherwise, the lid sutures also in 7 to 10 days. Blepharophimosis is a variant of ptosis, so you should understand that in these type of situations, it is not only the ptosis correction which you need to do, but you also need to take care of the horizontal fissure width. So, and these run in families. So this is after doing 2 stages of blepharophimosis correction. The first one was for the horizontal fissure, and the second one for the vertical fissure height. In acquired aponeurotic, the most common one being senile aponeurotic, which is like age-related aponeurosis, aponeurotic ptosis. Could be myogenic, which is myasthenia gravis, or CPEO, which is chronic progressive external ophthalmoplegia. This comes over adolescence. After second or third decade, it starts showing and progresses with age. Neurogenic, third nerve palsy could be there. The patient may present with sudden onset ptosis, and the movements of lateral down and up gaze could have been gone. Sometimes there is a pupil involvement also, the dilatation of pupil. The traumatic, mechanical, and so many more variants are there. I will not go into the detail because we have less of time, but probably we all know myasthenia gravis is fluctuation of ptosis, could be accompanied with variability, squint. Eyes compresses can be done for an eyes test in the office. Then we have various tests for assessing neostigmine test, as well as RNST, which is repeated nerve stimulation test, and physostigmine helps. So in clinical presentation, sometimes patient gives these histories. You should always ask these proper histories, and then you can define whether you are dealing with a normal ptosis or a myasthenia gravis. Like this seems to be a simple case of ptosis, but she was a case of myasthenia, which could be helped with medicines. I'll skip these slides. Ocular motility deficit should also be noted, like pseudo patterns, Duane's and all. Sometimes they have pseudo third, fourth, sixth nerve palsies and some sinus syndromes. These are the diagnostic tests for myasthenia gravis: anti-acetylcholine receptor antibodies, tensilon, electromyography, response to mestinone, that is giving a trial of physostigmine test, and eyes test, putting the eyes on the lids, on the closed lids, and see within 2 minutes whether there is an improvement in the lid height or not. In cases of CPEO, generally we should not be doing surgery, so we use crutch glasses to help the patient and to lift the lid. And also in cases of neurogenic ptosis with third nerve or not, where you can use crutch glasses to tide over the time till when the patient is improved on with the neurogenic ptosis. So these are few results. So this is a severe ptosis with poor LPS section. A sling surgery was done, and a good result in primary gaze and sling. This was a ptosis congenital but acquired variant, so LPS resection was done. Good result again. This was an acquired ptosis, a middle-aged woman with good LPS section. LPS plication was done. Very good lid crease. If you see the post-operative result, you can't make out whether the patient has been operated upon or not. In this condition, again, it's an aponeurotic ptosis, acquired variant. This is an important picture because in this, if you see, there is an inferior scleral show, which you need to document in the ptotic eye. So once she was corrected, the eye was very well corrected, but the patient appeared to have a higher correction because the vertical fissure eyes had increased. This was because of the inferior scleral show, which was persistent even after the surgery. So at second stage surgery for correcting the inferior scleral show was done, and now she had a very good correction. Sometimes you have a pseudotosis because the other eye is having retraction. This is a huge lid height, but sometimes the patient comes to you like thyroid related things or some other retraction syndromes where you may need to adjust the height which is higher, and then you correct it by doing an LPS recession by removing the strength of the LPS. I wanted to acknowledge these two guys because that video was prepared by Dr. Santosh and Dr. Roshmi, but unfortunately that video didn't play. Thank you very much for your kind attention. A couple of questions if you want. Yeah? ऊंचा बोलना पड़ेगा, माइक नहीं है तेरे पास. Modify surgery in case of Marcus-Gunn phenomena. That's what you're asking? Okay. Marcus-Gunn phenomena, there are two things. The literature says that in case you want to correct Marcus-Gunn phenomena, because you can't denervate the LPS Okay, so you have to excise the LPS, not only of the diseased eye but also of the normal eye. So both the LPS needs to be excised. So both will become ptotic. Then you do a sling surgery because LPS is gone. You can't do LPS procedure. So bilateral surgery has to be done. That will create a symmetry and will take off the Marcus gun. But I am not convinced. I don't do it anymore because I myself think that doing a normal eye for Marcus gun is not so acceptable to the surgeon as well as to the patient and to the attendants. So what I do is, and to tell them is, and over the period of experience I've found is that once you correct the ptosis, so initially the excursion was from, for example, this was a ptotic eyelid. So it was a Marcus gun phenomena. On opening the mouth, it was going like this. So once you correct the eyelid to this position, the excursion will remain only this. So you would anyway decrease the excursion to quite a bit. So that if you counsel the patients well, that it will be decreased to quite a bit, and there is no harm doing it, and we won't be touching the normal, and they are quite convinced. Until now, only one or two cases I remember in the last 20 years of my experience that they would have still complained of Marcus gun. Otherwise, most of them are very happy. I invite Amit back for the next talk of his.
So now we'll be discussing regarding the tips for evaluation and management of strabismus. So what I usually tell is that like I discussed earlier also, that our evaluation starts right from the time the child or the patient is entering into the clinic. So they can give you a lot of clues regarding their face turns, head tilts, chin positions, which can go a long way in making your diagnosis. So birth history is very important because a lot of them, they would have some kind of history of developmental delay, some birth asphyxia. So all those would be very pertinent in terms of what kind of management do we aim for these patients. Similarly, for developmental milestones, family history, intermittent exotropias and accommodative esotropias, roughly 10% of these patients, they have their family history of the similar condition. Any past history of any glasses that they have used, there has been a repeated change in glasses, any surgical intervention that they have undergone, any kind of amblyopia therapy that has been done. So all those things would be very, very important when we are discussing or when we are diagnosing them. Any history of diabetes, hypertension, hyperlipidemia, CAD, these would be very, very important, especially more so for adults who have some kind of ischemic nerve palsies. So when we talk about the history, the age of onset is very, very important. So infantile esotropia, classically the onset would be in the first 6 months of age. Accommodative esotropia, classically the age of onset would be 1 to 3 years of age, despite we have some cases which have an infantile onset accommodative esotropia, which can have an onset of even up till 6 months of age also. Intermittent exotropia, classically the age group is 1 to 3 years of age. So they can help you guiding your diagnosis in the first instance. Defective vision, you have a child the parents are complaining that the child has vision in one eye which is lesser compared to the other eye. You know for sure that there can be a component of amblyopia also, and we have to deal with that beforehand. Any asthenopic symptoms, any head posture that we have already examined also, and the parents are also complaining. Any abnormal eye movements in the form of nystagmus that we are seeing. Diplopia and visual confusion is very, very important. So when we go into diplopia, so we need to know what kind of diplopia, whether it is monocular, binocular, vertical, horizontal, torsional, or it is a combination of these, and any particular position that it tends to alleviate the diplopia. So evaluation of diplopia is very, very important, and accordingly we manage these patients. I am commonly asked a question that what is the age that we target these patients should be operated. So this is a child with infantile esotropia, presented at the age of 4 months, was being followed up till 8-9 months of age, and this child has been corrected with a surgical correction by medial recession and is perfectly orthotropic, and this child has completed roughly 11 years of follow-up now and has a stereopsis of 50 seconds of arc. Normal stereopsis is 40 to 70 seconds of arc. So this is what a good timely intervention can do for the child. So we can have both a sensory and a good motor outcome for these children, provided they present early, they are managed early. Myasthenia was something which was diagnosed earlier also, discussed earlier also. This child presented with intermittent exotropia to begin with, very good control, was asked to follow up. Over a period of time, developed something like this. There was a variable ptosis in both the eyes, managed with paradoxigmin and oral steroids. So this is on follow-up when the steroids and pyridostigmine have been increased, has cushingoid features because of that. This is what the child started with, and this is on steroids, and this is on tapering of steroids. So cushingoid features, they tend to wean off over a period of time, but they have to be continued on oral pyridostigmine for a very, very long period. We gradually taper off that also in some patients. We discussed about diplopia. So first picture, if you look at, the patient had a history of trauma, had an exotropia, and also has a iridodialysis. So a cause for both monocular and binocular diplopia in that patient. So we fixed the iridodialysis for that patient, and then we did a surgical correction of strabismus to take care of his binocular diplopia. So the both could be taken care. Second picture, if you look at, can you notice something? The edge of the lens is visible. So that is the reason for monocular diplopia. Third picture, anything that you can point out? You see this day in and day out. So there it is inferiorly placed. What is the classical position? 10 to 2 o'clock. So it is covered with the lid. So inferiorly done PI is another reason for monocular diplopia. So we need to look at all these features. So anterior segment evaluation in strabismus is for multiple reasons. So we are looking at a lot of other things, not besides only the strabismus evaluation. Inspection, as I already mentioned, as the patient is entering into the clinic, so the examination starts right from that time. Anterior segment, I've already elaborated. Visual acuity according to age appropriate measure. So if it's a child, pre-verbal child, the methods would be different compared to verbal child. Adults, anyways, Snellen's, ETDRS or whatever the patient is cooperative or is understanding, we can do any of those. Refraction, cycloplegic refraction would be required for a lot of them, though adult patients will have a subjective refraction also. Whenever we are treating a child with strabismus, always amblyopia first. So we have to treat amblyopia before any surgical intervention if we are contemplating any surgical intervention at a later date. This child had a cracker injury following which had a cataract, underwent a cataract surgery, pseudophakia in the right eye, amblyopia in the right eye, glasses prescription given, patching done, and then the surgical correction for exotropia would be done at a later date. The role of refraction in esotropia can never be underemphasized. So this child has a 50 prism diopters of esotropia, did a cycloplegic refraction, full cycloplegic refraction prescribed, has a fully accommodative esotropia, which we call it refractive accommodative esotropia. Compared to this child, has a esotropia of 30 prism diopters, prescribed glasses, has more esotropia for near. This child has a high AC by ratio for which we have prescribed a bifocal segment. So the management would change according to patient basis. Again, another child, 40 prism diopters of esotropia in the first picture, prescribed glasses, still residual 30 prism diopters of esotropia, underwent a surgical correction for the non-accommodative element in this partially accommodative esotrope. Is orthotropic. After the correction with glasses would be corrected with glasses. So we have to tell them again and again that the glasses still would be required, but we'll need surgery for the non-accommodative element. Commonly, we discussed the hyperopic glasses having an impact on the strabismus. This girl has if you look at the first picture, 20 prism diopters of esotropia in the first picture. This girl requires minus 20 diopters of myopia. If you now measure, this measures around 40 prism diopters of esotropia. So when we are contemplating a surgical correction for these patients, we have a different set of nomograms, and accordingly we deal with these patients. Otherwise, these patients would tend to go into an exotropia and would have an intractable diplopia, which is very, very difficult to manage. So if we look at this 9-gaze picture, it essentially seems like as if it's a 1-gaze picture and which has been posted in all the 9 gazes. These are the 9-gaze pictures of these patients, and the globes are practically frozen in 1 gaze only. So this is an extreme form of high myopia, myopic strabismus fixus. So this patient, probably maybe 2 sets of prisms would not suffice the measurement, had more than 150 prism diopters of esotropia. We did a CT scan for this patient, very large globes practically touching the orbit. And if you see at the muscle positions, the lateral rectus is significantly infraplaced and the superior rectus is significantly nasally placed if you look at this picture. So there is a pulley heterotopy which is there. That is mainly because of a connective tissue abnormality which is both there in the sclera and the muscle pulleys, which leads to displacement of these muscles and the eyeballs moving in this direction, and that leads to practically this. This is extreme form, and these are the intraoperative pictures of this same patient where the lateral rectus is significantly infraplaced and the superior rectus is significantly nasally placed. And what we did for this patient was a bilateral loop myopexy with a bilateral medial rectus recession, and this is the post-operative picture of the same patient. Still has some amount of residual esotropia, but very, very gratifying for the patient. And now we could do refraction for this patient after the surgery. This patient had minus 30 diopters of esotropia, and the axial length was close to 35. So you can imagine what we are dealing with. Still, we cannot give movements for this patient because the globe was touching the orbit if you had seen the scan earlier. So the globe was practically touching the orbit. So we cannot ensure movements in this patient because there is no space for the eye to move practically. At max, we'll have to do an orbitotomy only for that. When we do a motor evaluation, always pay an attention to the head posture. So first picture has a head tilt, second one has a chin depression, third one has a face turn. So there can be a variety of reasons for that. There can be a sixth nerve palsy for a face turn. There can be nystagmus also for the same reason. There can be unconnected refractive error which can lead to this. There can be heminopias also which can lead to this. So we need to figure out what exactly is the cause for any head posture. We come across children in the age group of 8-10 months of age with a significant head tilt. Uncorrected high astigmatism is a very, very common cause of having a head tilt. So we need to look at what exactly is the cause. So this 11-12-year-old boy had gone to multiple places carrying multiple envelopes of their reports, gone to an orthopedician, neurosurgeon, physician, and was advised surgery for releasing the sternocleidomastoid. But this is what was missed. So there is a significant superior oblique palsy in the right eye, which was the reason for this head tilt. So we need to do a good ophthalmological examination for all these patients. I would say 99% of these patients of any kind of face postures are because of ophthalmological causes. And we are able to figure out most of these causes. Very rarely these are habitual causes. We don't need to do anything for that, just reassurance. So if you see this picture, there is a significant vertical deviation which is there in the primary gaze. And if you look at the right gaze of this patient, there is an inferior oblique overaction. And if you look at the left down gaze of the patient, the left eye is not moving down at all. So there is a superior oblique underaction in this patient. This is because of right superior oblique palsy that the patient had this face turn, head tilt. Underwent a inferior oblique myectomy with a superior oblique tuck in the right eye, and the head tilt has been perfectly corrected. Still had a little bit of residual deviation, but the parents were very happy that the head tilt has been corrected and they didn't want any further intervention for the same. So these are the 9 gaze pictures of the same patient where you can hardly make out any vertical deviation now. Another boy was 18-year-old footballer by profession, had diplopia because of which he was trying to discontinue his footballing career. He had a sudden decompensation of his superior oblique palsy. Again, right superior oblique palsy accentuated in the left gaze where you can see the up over elevation and this eye not moving down. So we did a right inferior oblique myectomy for this patient and was diplopia free. All gazes orthotropic, and this boy could again resume his footballing career after the elevation of diplopia. This patient had come to us only with a chin depression. That was the only complaint following head trauma. He had a fall from height, following which he had only this chin depression, which was the only complaint. If you look at this picture, practically seems as if nothing is there. But if you look at very closely the 9 gaze pictures, there is an over elevation in the right gaze, in the left eye. Inferior oblique overaction in the right gaze. Very mild inferior oblique overaction in the left gaze, also in the right eye. When we measured, typical pattern of a V pattern esotropia and an alternating hypertropia in either of the head tilts. Any of you knows about the Parkes head tilt test? Maybe time is less to dwell on it. So This patient had a V pattern esotropia, alternating hypertrophy in either of the cases, had a bilateral esopalsy. So this patient, and this can be also seen on the fundus photos where there is a significant extorsion. Normally what you expect the eyeball, the fovea to be at the border of middle 1/3 and lower 1/3 of the disc. But here it is below the inferior border of the disc. So this is because of the extorsion, which further augments our diagnosis of bilateral esopalsy. This patient underwent a bilateral Hararaito, following which he was diplopia free in all the cases. I'll skip this for paucity of time. So Hirschberg test, most of us are doing in our daily OPD. So what we do in this, at 33 centimeters, you shine the torchlight and see for the centration of the reflex. If it is nasally placed, it indicates an exotropia. If it is temporally placed, it indicates an esotropia, accordingly, and similarly hyper and hypotropia. Pseudostrabismus is something which we see day in and day out, especially more so with children who have a wide nasal bridge. Very, very common. The parents come with that anxiety that my child is squinting, and this we are seeing since birth, and it is gradually decreasing over the period of time. Pseudostrabismus is very, very common in the OPD. Common causes, telecanthus. Epicanthus is the most common cause that we come across. So what do we do in a cover test? So we cover the eye, which is the normal seeing eye, to see the deviating eye. It is for tropia. So whether the deviating eye, it is taking a fixation or not. So it tells you both whether the fixation is there or not, and we are doing it for tropia. Compared to an uncovered test, which we do for a phoria. So look at the eye under the cover. Once we remove the cover, the eye is taking a fixation again. So this is an exophoria. So look at the eye under the cover, it moves back again. So it is taking a fixation. This is an exophoria. Compared to this is a patch test being done for a patient with intermittent exotropia. You put the cover in front of one eye and you alternate the cover. That becomes the alternate cover test. And once you introduce the prism in front of one of the eye and you measure it, that becomes the prism bar cover test. We don't use prism bars anymore. We use loose prisms, but we call it as prism bar cover test. And you keep on increasing the amount of prisms till the time you have neutralized or you have a reversal. If you have a reversal, then you decrease the amount of prisms and you get your neutralization point. And once we are measuring, we measure both for near and distance, and we measure in all the 9 gazes. Even if we are not measuring it all for all the 9 gazes, up and down gaze and right and left gaze are mandatory to see for any lateral incompetence or a vertical incompetence. Vertical incompetence like we see in this patient. So this patient has a exotropia in the primary gaze. There is an inferior oblique overaction in both the side gazes, and there is a V pattern. So V pattern is very, very characteristic for this patient, and accordingly we plan our surgical intervention for this patient. This patient underwent a bilateral lateral ictus recession with an inferior oblique myectomy in either of the eyes, and is orthophoric in all the cases. So our evaluation in strabismus is the first and foremost thing, and that is the only thing that is required. Surgery is relatively easier. Again, another patient, if you see the primary case picture, has a 40 prism diopters of esotropia. But if you look at the left upper gaze, what do you see there? That eye is not elevating at all. So this patient has a Brown syndrome with an esotropia. So this patient underwent a bimedial recession with the inferior right superior oblique tendon expander, what we call the right expander, which gave the upper movement also for this patient. So this patient was orthophoric in all the cases. We could recover the movement as well. So the planning of strabismus cases is very important. It is very, very common. I see a lot of patients who have been operated for horizontal strabismus and vertical has always been missed. Very, very common to see this. Krimsky. So if you have a patient, especially an infant, who's not able to cooperate with you for cover and cover test or prism bar cover test, we do a Krimsky test. Or for those patients who have a very poor vision in one eye, there we rely on the modified Krimsky. You put the prisms in front of the normal seeing eye, and then you measure the amount of strabismus which is there. And accordingly, we plan any surgical intervention if at all required. Whenever we are doing an examination, extraocular motility would be very, very important. If you look at this patient, there is no abduction in the left eye. This patient had a left sixth nerve palsy falling trauma. So movements would be first and foremost thing that would help you plan your surgical intervention if you are planning one, or a medical management if you are planning, like for this patient, traumatic case, I'll like to wait for 6 to 8 months. If at all it doesn't resolve, then only I contemplate planning any surgical intervention if at all I have to. Another patient, 40-year-old, presented with diplopia for the last 1 week, following a history of fever, which is very, very important. This patient had a -1 limitation of abduction in the left eye. What is the normal extent of adduction? So the normal extent of adduction would be nasal 1/3 of cornea should be crossing the punctum, or should be crossing the lateral. It should reach the extreme end. Compared to a normal extent of abduction, the lateral limbus should be touching the lateral canthus. So that would be the normal extent of adduction and abduction. And based on whatever the amount of limitation is there, we grade it as -1, -2, -3, -4, and accordingly +1, +2, +3, +4. So we should be knowing the normal extent, then only we'll be able to know what is abnormal. I'll take 2 minutes more. So another patient, if you see, again, there is a limitation of abduction in the right eye. This patient had a Duane's attraction syndrome type 1 with an esotropia, underwent a bimedial asymmetric recession, and is orthophoric in the primary gaze. Though movement we have not dealt upon in this particular case, we have interventions for improving the motility in lateral rectus also. When we have a very large deviation, it is very common to miss out on the vertical deviations. Like this patient has an exotropia of close to 80 prism diopters, has a vertical deviation also. Esopalsy is also there in the right eye, which we could have fixed it in the first instance only. This patient underwent a bilateral lateral rectus recession with a medial rectus of one eye resection and an inferior oblique myectomy. And this is the post-operative picture of the same patient following one surgery itself. Orthophoric in all the cases. So we can correct these all things in one go, provided we have done a good evaluation for these patients. Whenever we have a movement limitation, always check for versions also, ductions also. Very common to have reported an underaction of one of the muscles. When because of overaction in one of the muscles, we commonly label it as an underaction. So we should always be checking ductions as well. Worth dots, stereopsis, more for theoretical. We don't use them that commonly now practically. Hair screening we use for those patients where we are monitoring them for their nerve palsies. The last slide. So very commonly we come across patients who have been operated sometime in childhood and they don't have any previous records. So here what we need to check is any presence of any scars which might be there. This patient presented with an exotropia, no surgical reports available, no previous photographs available, had come from Dubai for the surgical correction. What we could see was there are scars both on the medial conjunctiva. You can see some scars which are there, suggestive of previous medial rectus surgery. So probably medial rectus recession was done, and we planned for a medial rectus advancement for both eyes, was orthophoric in all the cases. So that helps in planning of these surgeries.
Thank you, Amit. That's why strabismus is a bit tricky subject, because evaluations are the key. Now we have Dr. Manu Saini with us. She'll be telling us about surgical corrections of ectropion.